right. Morning, everyone. Welcome to the Center for Global Development. My name is Jeremy Kondyndyk. I'm a senior policy fellow here at the center, and my research focuses on, amongst other things, pandemic preparedness, which is proving to be a very timely topic these days. We have a fantastic panel for you this morning to look at preparedness for the coronavirus outbreak. And just as a lead-in before I introduce the panelists, many of you probably saw last night an announcement of another 14,000 plus cases in China, another 200 and some deaths. So a large spike in numbers. The outbreak seems to be continuing to grow. There are, there are fears that are pretty widely expressed in the public health community that what it is doing in China could be replicated elsewhere, and there is a risk of community transmission in many other countries, not least even potentially here. WHO has expressed very serious concern about threats to the developing world, and in fact, when Dr. Tedros made the declaration of a public health emergency of international concern, that was one of his major rationales for the declaration, that he was very fearful of what this disease might do in a developing country context. And even we've seen in the last few days a shift in U.S. government rhetoric away from the sort of framing of the risks to the United States. It could happen, we're just not seeing it yet. So even the recognition in the U.S. government side that they're going to look at the needs of frontline health responders in the developing world and in the U.S., and then we're going to look at mitigation strategies and the dimensions of preparedness for a mitigation strategy if control fails, as it appears it might. So we have a fantastic group of panelists to talk about that here today. On the line from New York City, we have Dr. Saira Madad. She is the Senior Director for Special Pathogens for New York City Health and Hospitals, where she leads that health system's preparedness for diseases like coronavirus and any other special or weird pathogens that may show up in New York City, which is pretty much anything that shows up anywhere in the world. So she will talk to us about frontline healthcare preparedness in a U.S. setting and how ready we are here in the U.S. We'll then turn to Dr. Tolbert Nyenswah, who is now a senior scholar at Johns Hopkins in the School of Public Health, but previously was a deputy minister of health for Liberia and ran Liberia's response to the Ebola outbreak as the incident manager throughout the entirety of the Ebola outbreak in Liberia. And so many of you, I think, know and recognize him well from that period. We'll have, so Tolbert will talk to us about preparedness in a developing country context and how ready the developing world is and what they might need in terms of support. Then we'll turn to Dr. Jennifer Nuzzo. Dr. Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security, and her work focuses on global health security and outbreak protection, detection and response. And we'll turn to Dr. Dan Hanfling, who is vice president at In-Q-Tel, where he works on the B.Next initiative, which looks at national security implications of infectious disease outbreaks. And finally, we'll turn to my colleague, Prashant Yadav, who is a visiting fellow here at the Center for Global Development and an expert in global health supply chains, to look at some of the pretty important issues of supply availability in an outbreak like this. And we're already beginning to see crunches in terms of supply availability now before it's even spread at large scale beyond China. So that will be a major issue if it goes to a larger scale. So it's a great group. I want to turn first to Dr. Madad. Before I do that, I'll just say, so we have a lot of people tuning in online. If you would like to pose questions to the panel, please tweet to hashtag CGDTalks, hashtag CGDTalks, and we have colleagues here in the room who are tracking that hashtag and will share with us some questions from the internet. And I can then pose those to the group so that you can take part that way. So with that, I'd like to turn to Dr. Madad in New York. So Dr. Madad, how would you assess the state of readiness within U.S. frontline health systems for a surge in coronavirus cases, and what do you think would be needed to more effectively ready the system for what could be coming?
So thank you, Jeremy. I think starting off first, as we know, it's still seasonal flu time. So we are already, in terms of resources and staffing and space that I'm going to get into momentarily, during normal seasonal flu time, we're already stretched, looking at the number of patients coming in with influenza-like illness. So to put on top of just normal seasonal flu, this surge of potential cases with, novel coronavirus disease, it would certainly tax any type of health system, whether it's in New York City or anywhere else. And so I think from that context, it's very important to be able to prepare for these types of events, and that's exactly what we're doing. We have this window of opportunity to see how we can better prepare our front lines in regards to the staffing structure that we have in place, our supplies, the space that we have, and that's exactly what we're currently trying to do, is just kind of working through long-term, goals. If this outbreak comes to the United States and we have community transmission and we have a surge of cases like another kind of seasonal flu, but 10 times worse, what do we need to do to prepare our sites? So right now, based on just seasonal flu time, usually systems are at maximum capacity because of the volume of patients coming in, but there's still a lot to do, obviously, in preparing for another surge incident. So I can certainly talk to high-level kind of recommendations and, strategies that we're starting to put in place to potentially, mitigate and prepare for another kind of seasonal flu type incident, and obviously something that would most likely be much worse.
And what sort of support or guidance are you getting or might you need in order to be more fully ready for that kind of surge in cases?
Right now, we're fully relying on our public health agencies and colleagues to provide guidance in terms of obviously clinical case definition. But I think there's a number of things from a healthcare standpoint that we're still looking for guidance on, and this includes surge strategies, crisis standards of care, conservation strategies when it comes to not just personal protective equipment, but other medical supplies. And we know in these types of incidences, this is obviously a novel respiratory disease. They're based on some of the studies that we're seeing that's coming out of China. A number of these patients suggest, lengthy hospital stays in ICUs. And so we need to make sure that based on that, we have the proper, staffing and space available along with the equipment. And so we want to look at guidance that can come out, whether from public health or something that we have to kind of develop, on the whim, if you will. And that's what we're doing in terms of looking at, how we need to move forward and look at conserving some of the supplies, but being able to provide the best patient care possible.
So Tolbert, I'd like to turn to you now to tell us what does this look like in a country like Liberia, in a developing country medical context. How ready do you think the systems are in Liberia or in other countries in the developing world, and what sort of support should they be getting in this next critical period before there could be a surge in cases?
Thank you, Jeremy. I think that's very important to look at this stage for the benefit of our audience. What we were dealing with in Liberia as the incident manager and the team there on the ground during the 2014-2016 Ebola outbreak, we were dealing with the first worst unprecedented outbreak in the history of the world. And the reason is described unprecedented. It was the impact it had on the society, the regional dimension of the disease. 3 countries affected in this case, Liberia, Guinea, and Sierra Leone. The first time for Ebola to affect a large population. Monrovia alone is about 1.5 million people. The first time the world dealt with Ebola was with like 90 cases or 100 cases in DRC. The confusion, desperation, fear, and everything that characterized the Ebola outbreak in West Africa was one of the things that the world saw that this was really, really unprecedented. And today, I see some of the confusion in what is happening with the coronavirus disease as we speak now. And Jeremy, if you look at the challenges the health system faced at the time when Ebola struck in 2014 in Liberia and in the region, weak health system occasioned by 14 years of protracted civil war, lack of healthcare workers, limited healthcare workers with the techniques to deal with the disease. We didn't have the isolation centers to isolate the cases with the kind of transmission rate of Ebola. Testing capacity was an issue, as a challenge. I remember we were taking 90 days to know a result of an Ebola case, traveling from Monrovia to the border to Guinea and moving towards taking samples to France to get it tested. We had to build specialized treatment unit. Jeremy was in Monrovia leading the USAID team to make sure that this was done. But we stood up an IMS system, incident management system, as a coordination team that didn't exist in the country. Those kind of capacity are not in developing world. Those are kind of the challenges that we saw during the Ebola outbreak. And some of the lessons that we learned that are applicable to today is that community engagement was very, very key. Behavior change, community engagement, simple things like hand washing. I remember every home, market store, everywhere in Monrovia, in the region, people were washing hands. And with coronavirus disease, these same lessons apply. We look at the system and what happened during the Ebola outbreak. We were able to stand up a National Public Health Institute in Liberia that is now about 3 years now with capacity to detect, prevent, and respond to disease outbreak. That system was tested when we had a flare up of Ebola after the 2014, 2015, 2016. So I describe that as a two tails of an outbreak, where you saw the one in 2014 with almost 11,000 cases, 4,800 deaths. And then flare-ups in 2016 with the same scenario, case coming from Guinea, but with limited cases and limited deaths, like about 20 cases, 7 deaths. So that's how the capacity was tested. And other countries in the region, like Nigeria, you saw what Nigeria did with the importation of the case from Liberia to Nigeria. They were able to use their surveillance system, a response system, to move on that. Now, Nigeria is responding to Lassa fever as Liberia is responding to Lassa fever in other areas in the region. But this don't cause panic right now because of the lessons in the system. Part of the lessons that we learned in the region, in Liberia, a developing country in Africa, is the Africa Center for Disease Control. Now, the leaders of Africa, AU, came together and put together a specialized agency called the Africa CDC that is headed by my good friend, Dr. John. We have regional centers in the north, central, west of Africa that is now putting in some measures with airport screening, looking at RPC measures, training for testing, and all of that. So moving forward with the coronavirus disease, one of the things that I see for preparedness moving forward is, number one, the testing capacity. It was taking us 90 days to know that we were dealing with Ebola. So if we would take a country more than 30 days to know whether or not they're dealing with coronavirus disease, with the proximity, respiratory nature of this disease, you will find out that we'll have more cases in the developing world before we even know what we're dealing with. And a disease everywhere in a little corner can affect any capital. We saw it with the international spread with Ebola. So evolving, putting in place the right information, strengthening our surveillance system, heartening surveillance at the port of entry, making sure that isolation units are in place in case a case come online, and putting in place surveillance for severe acute respiratory infectious diseases will be great. And the kind of supply chain and research with countermeasures, those would be my advice.
And how close do you think a country like Liberia is to being ready on these, or what kind of support would be most urgently needed in the next, say, month or two? to bring these things up to better capacity.
If I would talk about the first important thing to do is to put the testing capacity in place, because of the creating of the National Public Health Institute, and in the African region, other national public health institutes have been created, so there is some capacity for preventing, detecting, and responding to outbreaks. Countries that have dealt with Ebola, like Liberia, have some capacity to deal with this. There are emergency operation centers that are in all 15 counties in Liberia. They can be activated and reactivated very quickly. But looking at what I'm reviewing and having discussion with the Africa CDC, we had a conference call just last week with the Africa CDC. One of the things that they try to do is to give some of the labs that are certified capacity for testing. So, for example, if a case is on an airplane right now and land at an airport in one of the regions, the developing country, isolating the patient, doing the test very quickly, knowing the results, putting the system in place to respond, reactivating an incident management system if it doesn't exist. Those are the things we will look at right now. But priority-wise, I would think testing is important.
Okay.
Yeah.
That's great.
Jeremy, this is Sarah. I
Please
wanted to actually add in terms of testing as well. Right now in the United States, as we know, the turnaround time for testing from, a hospital standpoint is still a few days, at least, 48 to 72 hours. And I think from even a United States standpoint for our frontline staff, we need to have better diagnostics even at the bedside, because as we know, we only have over a dozen patients here in the United States. And even then, we have a run on PPE, and we're having significant issues from a supply chain point of view on personal protective equipment, particularly N95s. And so when you have, even 2 or 3 days patients in isolation, you're burning through additional supplies. And in this current climate where we're forecasting additional supply chain challenges, I think it's very important. I think the number one thing, again, even from a U.S. standpoint, is being able to have that diagnostic capability at the bedside. I think the other thing is obviously a number of vital supplies and medication that is, that we rely on a just-in-time kind of format. We need to obviously look into that, and that's something that from a frontline capability standpoint, we are looking into to see, if we're having additional, not just, issues with PPE, but even medications that may be coming out from other countries here to the United States. What are our mitigation strategies? So it's one of the things that we are looking at, and just in terms of some of the supplies and equipment that, we're trying to mitigate through, but also in terms of just space. As we know, in these types of instances, they require negative pressure isolation rooms, and in a healthcare facility, there's very few of these. And if we're looking at, facilities outside our brick and mortar, for example, putting up tents or alternate care sites, we would have to have the capability to be able to provide that particular engineering controls. But I think the biggest question that really comes into place, at least for the United States standpoint, is who's manning some of these alternate care sites. If we're already going to have a significant hit on staffing, which is our number one asset in a healthcare facility, that ratio from patient to provider will significantly go up. And as we've seen historically, when those numbers go up, you see an impact to patient care. Specifically even, infection control measures. And as we've seen some of the studies coming out from China, a number of healthcare workers being infected, this indicates a breakdown in infection control and prevention measures. And so from our standpoint, just-in-time training is extremely important, but is also very taxing. So being able to educate frontline staff right away of, again, infection control measures to take, how to don and doff properly. But I think another big thing is if we have to, midway through the epidemic, change some of our PPE because of the impact that we're seeing. So, for example, if we're going with one manufacturer of an N95 and midway through an epidemic, we have to change that manufacturer because that mask is no longer available. You have to then fit test a huge workforce. And with, for example, New York City Health and Hospitals, we are over 40,000, individuals. And so that takes a lot of time and effort. So I think looking into some of those measures too. And I think the last thing in terms of guidance is, again, funding. So strengthening biopreparedness funding for healthcare systems. And as you may know, right now, the funding that was given to healthcare systems in 2014 for Ebola and special pathogens, that's set to expire in 2020. And so with this type of environment that we're in from a system standpoint, there's little advantage or incentive for system leaders to invest in preparedness when funding is constantly shaky. So I think another thing to really look at from a national standpoint is being able to fund a number of these initiatives, especially not just when these outbreaks happen, but beforehand. But similar to what the current speaker just stated, I think we need to obviously look at, even on a domestic standpoint, a number of those nuances that are being raised.
So it's a pretty bracing picture that that Sarah and Tolbert present of the state of readiness right now in the U.S. system. A lot of capacity, but also that capacity is nearly fully taxed already by the height of flu season. And even at that level, with just a few cases in the United States, already seeing shortfalls of PPE and beginning to think about how to approach crisis care standards and some degree of rationing of PPE supplies and other critical medical supplies, thinking forward to some unorthodox approaches to beds and workforce coverage if there were a large surge in cases. And in a developing country context, even greater challenges with fewer medical staff, fewer facilities, and fewer resources. So there would be an enormous challenge if we did see large numbers of cases beginning to spread really anywhere outside of China. And it sure sounds as though the sort of challenges that China is facing now would be replicated in a lot of other settings, and the U.S. would not be immune to that. I'd like to turn now to Dr. Jen Nuzzo to talk about mitigation strategies and what we should be looking ahead to in the U.S. system if we do see spread here, and particularly some of these measures that the government has already put in place to try and prevent entry of the disease, the quarantining of the quarantining of incoming travelers and the ban on travelers from parts of China. Is that working? Is that effective? And how long should we keep that going before it becomes potentially irrelevant? Dr. Nuzzo.
Yeah, so just thinking back to where we started, and I think it's important to kind of reflect on the arc of what we've learned since the beginning. So, this initial outbreak of viral pneumonia detected in a healthcare setting by astute clinicians who saw patients who were probably not uncommon, but noticed something unusual, which was they had this common occupational exposure to the seafood market. And so based on that, they reported this to health authorities, and they initiated an investigation. Now what we have learned is potentially that connection to the market may have been a coincidence. It may be people that work together and were coughing on each other. What initially looked like potentially a limited point source exposure, we now know is a very large epidemic that is spreading quite easily between people. And in the 2 months or so since we first were alerted to this outbreak, the initial outbreak, we've now come to appreciate some aspects of the virus that we didn't initially know. The first one being that the majority of the reported cases are reported to be mild. So WHO says about 82%. We also know that the virus seems to be quite easily transmissible between people, and between people potentially very early in their illness. There's some question as to whether people without sort of visible or notable symptoms can transmit, but nonetheless, people who are quite early can transmit it. And we also now know that from that one JAMA report and from potentially some other news reporting that perhaps large numbers of healthcare workers have been infected. And so what this tells us, I think it's really important to focus on these details, because one of the things it says to me is that this virus is very different from SARS. SARS, we didn't have this level of mild illness. People tended to transmit later in their infection. And those aspects, although it made it a quite deadly, it was a quite deadly virus and a terrible virus, it made it easier to control. When you have a virus like this one that is spreading quickly between people with potentially very non-specific symptoms that could easily be mistaken for something else. We've heard that some of the initial cases didn't even fully know that they were sick when they potentially transmitted their infections. It becomes very difficult to think about how to interrupt that transmission. And it also is very difficult to know where all of your cases are. And so what we're already seeing, and there's been a lot of press attention in the last couple of days about China changing its testing strategy, we are already seeing that there may be many, many more cases out there that weren't previously counted. And what the impact of changing testing strategies, we still have to judge that. But nonetheless, when we think about trying to pursue containment, this goal of stopping the spread of the virus, absolutely, that is very, very difficult to do when you don't know where the virus is. And when we think of what countries' approaches have been to containment, it has been tied to geography. This idea that we are screening and testing people based on whether they've been to Wuhan specifically, but potentially also China. We now know that 24 countries in total have reported cases. In 11 of them, there have been instances of local transmission. For the most part, tied to known contacts, but nonetheless, transmission in those countries. When your testing strategy is only, in most countries, testing people who have traveled outside of your country, that means you are likely going to miss any cases that originated somewhere else. And so the impact of this was seen in the United Kingdom, where they had a case that they discovered in someone who hadn't traveled to China. He had gone to Singapore, where we know local transmission is happening. We also know in many countries, including the US, testing is contingent on the severity of symptoms for the most part. And so that means that maybe these 82% of cases that are mild, if they didn't happen to have a travel connection to Wuhan City, might be missed. So when I put that together as an epidemiologist, I look at 24 countries reporting cases. I know that surveillance is quite biased to miss cases that are either mild or that have originated outside of China. I know that many countries haven't yet developed testing capabilities. To me, that says that we actually don't have a good map of where the cases are in the world. And from a public health standpoint, that may not be as bad from an impact standpoint, right? We're not large numbers of deaths. I mean, I want to point out to the point of, will we see something like what's happening in Wuhan? We don't yet know why the cases outside of China have been mild compared to what we're hearing in Wuhan. And I just want to I think that's a very important detail for us to reflect upon before we project too far of, are we going to be in that situation where we're talking about rationing care, et cetera, like that. But nonetheless, just taking it from a containment perspective, if we don't know where the cases are, how can we possibly protect ourselves with a geographic-based strategy? And so you're already hearing people starting to shift language a little bit, saying, well, these aren't meant to keep the virus out. It's a layered measure. We're doing this so that we can capture people and study them. I have to say, enrolling people against their will into a scientific study is something that we should question, which is essentially what we're doing with some of the quarantines, particularly on the cruise ships. But nonetheless, I think the great fear that I have, because people will say, well, even if it doesn't fully work, shouldn't we try it anyway? And my answer to that and my concerns about that is that if we could do that and still plan for mitigation, that would be a different scenario in my mind. But what we are seeing, and I think Syra and others have already pointed out, we have not done the full work to prepare for mitigation that we need to do. And it's not a surprise, because it's the same people who need to do that work as the ones who are now trying to find hotels to put people that we're pulling off of planes and to transport them there with security because their safety is concerned, and to staff around the clock monitoring these otherwise well people for signs of illness and thinking about what to do. And it's just incredibly resource intensive work. And it's the same people doing it who would also need to do things like working with the health system and making sure we have plans for, who is going to receive care, what level of illness should receive care. Many places are using hospitals as de facto isolation facilities. I personally don't think that's a great idea to bring a virus into a health facility for someone who doesn't otherwise require hospitalization. But we need to work through these things. We need to work through what happens if we do have a large number of cases such that it exceeds our testing capability. Are we going to shift to what China is doing, where they're shifting to clinical diagnoses? We did that during H1N1. That might very well make sense, but we need to think about the messaging and at what point we're going to do that. There's just a lot of planning work that needs to be done that I have not seen compelling evidence that we are doing enough of.
The way you articulate that last point, it for me brings back memories of the July 2014 period on Ebola, where we know now that was the period when it was really exploding, particularly in Liberia. And the main focus of the U.S. government at that, or much of the U.S. government at that point, was on how do we medevac these 2 Americans who'd gotten sick. And it did divert attention because you're right, it is all the same people who ultimately have to work on these things. And Jimmy was there during that time and remembers this well. The number of internal high-level meetings we had on how do we bring these people back to the U.S. and where do we put them sucked up a lot of the oxygen. And at a period when we should have been thinking more about how do we scale up our response, we were instead focusing on that. And I do fear there's a sort of parallel dynamic in play right now. Mm-hmm. Dan, I want to turn to you next. We've heard from Syra about some of the crisis standards of care thinking that they're doing. We just heard from Jen about the lack of planning around that. You literally wrote the report about crisis standards of care for the national academies. So, with that experience, and as you look at how this is evolving, at what point At what point should we begin thinking about that? At what point do we begin triggering those sorts of standards, and what kind of preparedness should be underway now to either avoid getting to that point or be ready when we do get to that point?
Sure. So first of all, thanks for the opportunity to join you. I would say, as has been said already very eloquently, if you are not prepared, you're not going to be able to respond. And I think that is the essence of the work that we did a decade ago under the auspices of the National Academies, focused on what ended up being described as crisis standards of care. Crisis standards of care was and is a planning framework for catastrophic health response. It was developed in the interim between the first and second wave of H1N1 in the late summer of 2009 initially, anticipating that second wave of H1N1 could be a widespread, easily transmissible novel influenza virus. And we wrote 3 reports in 2009, 2012, and 2013 that detailed a framework for planning and response that essentially, in a nutshell, focuses on a couple of key elements. The first is the recognition that ethical considerations are front and center in making very difficult decisions. To Jen's point about enrolling patients without their knowledge in a scientific study. The second is equal to the ethical considerations is the importance of recognizing the rule of law. I mean, as Jeremy knows, I've been around the world, partly under your leadership at OFTA, responding to catastrophic disasters on the urban search and rescue side. And that's the last time that you want to sort of, take a cowboy's approach. That's where the rule of law is critically important, because people are watching and people are deserving a fair and equitable response, not just sort of made up as you go along. Then we highlighted a few key elements, one of which Tolbert just alluded to, which is that you need to ensure that there's both provider engagement. In other words, that community of providers who are going to care for patients need to be engaged in the planning and in the decision-making about what the response will look like, especially if it tends towards having to make the very difficult decisions about rationing of care or a reuse or reallocation of critical life-saving material. And then critically equal in importance to that is community engagement. You can't make those decisions, particularly if you get down the road towards having to talk about rationing life-saving care, without making sure that the community is engaged in those discussions. And actually, the Center for Health Security at Hopkins has done a lot of groundbreaking work on that, as have a few others. And then there are certain elements around understanding clinical processes and operations and making sure that there's a feedback loop, a sense and respond capability that allows you to make those mid-course corrections when you need them. So that is the framework in a nutshell. I mean, thousands of pages of reports that you can read online, but that is the framework that is now inculcated in the grants that come down from the federal government to the states, both on the public health and on the healthcare preparedness side every year. And being that it was a decade since we did this first report, in November, the National Academies held a 10-year review of what is the state of crisis standards of care planning. And unfortunately, some of the findings that we have come to, and the report, the proceedings from that meeting will be coming out soon, really demonstrate that there's been really spotty planning with regards to this. No surprise, I think, for some of the points that Jen has mentioned, and for other more concerning issues. The most obvious being that this is sort of a third rail of discussion. It touches on political decision-making. It certainly touches on liability concerns, and everybody likes to say somebody else is in charge. And that has been a problem. And, you know, so I would highlight the importance of crisis standards of care planning in that it is a proactive measure to be prepared. We hope to God that we don't have to use this anywhere, whether it's in sub-Saharan Africa or in the United States or anywhere else. But it's a process by which we think long and hard about how we would deliver care to those who would most benefit from receiving that care. And there are a couple of simple strategies that this is based upon. The first is conservation. How can we conserve the limited resources that we have? The second is substitution. Are there certain things that we can substitute to ensure that there are materials that can continue to be delivered? If needed, are there means for reusing certain equipment? And now I'm thinking about PPE, respiratory protective devices. And in the worst of worst case scenarios, do we have to reallocate resources? Think about a patient on a ventilator, a life-saving device that is breathing for them, but the patient is not getting any better. Is there somebody who might benefit from that same equipment? So I'd like to highlight that the CDC has already taken a big step forward with regards to recognizing the importance of this framework. We describe a transition from conventional to contingency to crisis care. Again, being proactive, hoping that you never get to crisis care, trying to stay within the contingency framework. And on the CDC novel coronavirus page specific to PPE, they highlight both the recognition that there can be some limited reuse of respiratory protective devices, N95 and other masks. And they also recognize the opportunity to move beyond extended shelf life. If you have material that has expired on the box, it says, the due date is over, but you still have it and it looks like it is viable, then it's probably reasonable to continue to use it. And there are other strategies that are being considered right now that move from the contingency to the crisis space. So to address Syra's concern, that guidance is needed, I think that the federal government is thinking seriously about what that guidance could look like, and there will be other materials forthcoming. Now, I want to highlight one other key point that my colleagues have made. If you can't see an epidemic, you're not going to know where it goes. And this is our single greatest problem. And so in the context of the work that I'm doing at In-Q-Tel, where we sit on the edge of the national security establishment, and we look at where innovative technologies can be brought to bear to address national security problems, and in this case, health security problems, we have the means to both be able to provide access to care as well as deliver on data that will provide us surveillance, very important surveillance information in the name of digital health platforms. Many of us on our phones now have the opportunity to connect to a doctor. So we have access to care. We have the opportunity to receive timely risk messaging. We have the means for taking that data and looking at it in an aggregated, non-personal information, protected manner, and begin to make sense of where disease might be spreading. And I think that is an important step for us to consider going forward. The other is rapid readout diagnostics. The marketplace doesn't support rapid diagnostics. I mean, look how long it took to get a point of care HIV test. 2 decades into the pandemic. And yet the scientific capabilities exist to be able to give us rapid readout diagnostics. And I think that that is something that we should be thinking about very seriously going forward. And if not for this coronavirus, then for the next one. Because if history hasn't shown us anything, it has shown us that the coronavirus does enjoy being in a human host and does seek to transmit person to person. And now this being the third coronavirus, jumping from animal species to the human population in the last 15 plus years, we ought to be thinking about the next one.
On triggering those sort of crisis standards that you were talking about, or kind of escalating your way down that ladder that you talked about, how close would you say we are now, or what are some of the indicators that would say, okay, now it's time to push to the next tier?
Sure. So the third of the 3 reports that we issued, which was focused specifically on indicators and triggers, with a recognition that crisis standards of care, it's not an all or none phenomenon. You don't come into the room with a bullhorn and say, crisis standards of care are now in effect. These occur over time and may occur in different geographic regions, at different times. So the sort of indicators I think that we should be leaning forward on now include, to the extent that we can understand it, the number of severely ill patients who are beginning to take up space in critical care units and other intensive care capabilities within the hospitals, also our emergency departments, staff shortages where staffing becomes an issue. We saw the South China Morning Post report from 2 days ago about 500 healthcare workers affected in Wuhan. Those are the sorts of things that would begin to be indicators that are moving forward. And I know that Prashant is going to talk about supply chain, but as the supply chain becomes an issue, that will be a significant indicator that we are beginning to make a shift. I want to make one other point, and it goes back to the severity of this illness, because we know the public is a fickle public, particularly when it comes to disease. I work in the emergency department just across the river at Inova Fairfax. People come in concerned with a lot of things, let alone coronavirus. And just that concern alone could crush outpatient and emergency department capabilities to sort of sort the wheat for the chaff and figure out who really is sick. So I would come back to the recognition that even if this disease is not as virulent, is not as severe as SARS or MERS, and thankfully so far the data is showing that, it could still present a significant challenge to the healthcare services in the United States.
Yeah. So the panic has a secondary impact over and above the actual disease itself, which is very much what we saw in Ebola as well. Prashant, I want to turn to you now. So we've heard a lot from several of our speakers about the difficulties keeping up with supply. How much do we know about the state of readiness within global supply chains to manage a big surge in cases and a big surge in demand? And if we were to see that huge surge in demand, how would we begin to approach and govern that? Because it wouldn't just be obviously a U.S. issue; it would be a global issue. And what kind of mechanisms exist to manage that, or what should we be doing to be ready for that?
Yeah. So I want to start by saying that I think from 2009 till now, we've come quite a distance in terms of at least having the set of ideas for how to run the PPE supply chain better and how to run the medical countermeasures supply chain better. And the national academies have done some work. So I think we have the ideas. Not all of them have been translated into implementation. Our progress since 2014 may not be as much, which you'll see as I talk about this. So I think that there are three kinds of supply chain issues that I believe are surfacing in the discussions. The first is the attention on the PPE supply chain. And I think this is both a US domestic and a global issue. So I think we've got to start by asking, do we know how much do we have in stock and what is our production capacity? And at this point, it is unclear where does the legal authority to get that information sit. And we may, at least for this time around, would have to work with some kind of a voluntary disclosure mechanism where we create a governance structure to say, here is where the suppliers are, here's the manufacturing capacity, how much is in inventory. The second part is, has to do with rationing rules. So if we get to a state that we have limited supply, which is very likely the case for PPE, then we have to think about what are the kind of inventory stock rationing rules we will use for what we would call as high priority demand, relatively less priority demand, and so on. And while we have some idea of how to implement them in the US, and CDC is already starting to issue some guidance to healthcare professionals, the ability to do that at the global level, where you've got global sources of supply and global demand, there still isn't a right mechanism that we have. And I think colleagues at WHO will work in moving things in the right direction, but just the lack of information about supply sources, inventory, manufacturing capacity will become a big hurdle. The third is identifying new sources of supply, right? So we get to a point where we say we need more new supply sources. And there again, I think our key challenge continues to be, and this is a persistent challenge for, as long as I've looked at this, we don't have a way to figure out what are our product specs, which can allow us to very quickly switch suppliers in case the need arises. So if I have a distributor, if I'm a hospital system, or if I'm a national government, and I want to switch because my current distributor doesn't have enough capacity or supply, when I have to switch, the specs are different, and this gets into, I think, what Sarah was talking about, having to retrain healthcare professionals on appropriate use for a new equipment. So a range of issues, but largely, I think, getting better information about how much is in inventory, what is manufacturing capacity, using some kind of voluntary disclosure mechanism for now, and for a longer-term policy standpoint, thinking, should we put this under the regulatory purview of an agency, FDA, equivalent for global. The second is the supply chain for medical countermeasures, which we don't have at this point, but let's think about a scenario where some of the new antiviral agents, which are now in clinical trial, lead to a good result quicker than anticipated, and we have a stopping rule which triggers us to start using them quickly. Then we would run into a situation where we actually know, for some antiviral agents, we know quite a bit about what the global manufacturing capacity sources of supplies are, and some of the newer ones we know actually almost none. And so figuring out how would we make decisions globally about who gets how much of a new antiviral agent will become a challenge. We don't have a global stockpile.
And where is it that a lot of those antiviral agents that currently exist are produced?
Yeah, so that's the third dimension of the problem, which is a large part of our pharmaceutical supply, especially active ingredients, come from China. Numbers may vary, but between 70 to 85% of active ingredient, irrespective of where the finished production is happening, is coming from China. It's also concentrated in Southeast, so it's also concentrated in Hubei. It is concentrated around Wuhan. So, and over the years, in our strive for efficiency, we've started running a just-in-time inventory system where we hold very little inventory at the hospital, less inventory at the distributor, and also manufacturers don't hold a lot of inventory because they're in smaller campaign sizes and so on. So as a result, overall inventory sitting throughout the system is smaller, and a few months of disruption will mean we will quickly start running out of stock of not just antiviral agents for coronavirus, but anti-infectives and other products more broadly. And that's a scenario which then gets into, should we invest in resilience in our pharmaceutical supply, and what would that mean? And I think there's a lot of work happening around that. I feel comfortable that we may be able to create something. It'll just be a matter of getting the right actors together. Then is the issue of and I think Dan brought it up, when we think about creating new sources of supply, whether it's for diagnostics or for other kinds of medical countermeasures, it is important to think about how will we sustain them beyond the current epidemic. And two options come up. One is, can we have long-term agreements with some kind of options contracting, which we've tried before. BARDA has done that with many of medical countermeasure suppliers. Can we create a global institutional mechanism to have such options contracts? The second is, should we think more actively about moving away from the one bug, one drug, one bug, one vaccine, one bug, one diagnostic, to platform approaches wherever possible? Examples would be, would you do just a Zika diagnostic, or would you do a Zika plus chikungunya plus dengue plus yellow fever diagnostic? And that way you can pool the demand from multiple pathogens together, and as a result, create a more stable source of supply. The same thing would hold for antiviral agents, same thing will hold true for vaccines. And those platforms will also allow us to get manufacturing capacity for the overall platform quicker. So when we think about especially rapid diagnostics, I think one of the questions that comes up is, are we as a society willing to pay a slight premium for a platform product versus a single pathogen product? Or same thing with vaccines and drugs. So I think that's an economic calculus. We've got to make much more effectively and say platform is better because it will allow us to sustain. The last thing I'm going to say is similar to Dan's comment about digital technologies, better surveillance. I think the supply chain depends critically on learning about demand as quickly as possible. And in the absence of that, the ability to respond is weaker. So as we learn about new cases, as we have incident management systems, we have digital surveillance tools, we don't have a clear blueprint of how does this information get communicated to different supply chain actors. And the supply chain is not one organization, it's not one entity or organization. There are several groups, agencies, manufacturers, firms involved. So I think that is another area where we've got to do better, which is how do we communicate demand side information or demand sensing quicker into the supply chain.
Right. That's so a really fascinating and kind of troubling set of interventions there about the degree of readiness, and clearly a huge amount of work that would need to be done if we do see large-scale spread, even kind of to a lesser degree than what we're seeing in China, but if we see large-scale spread in other countries around the world. I'd like to turn it open now to those in the room and those online. My colleague Noor has pulled together a list of questions that have been coming through from Twitter, so keep sending those. Again, if you're following us online, the hashtag is CGDTalks. So just tweet to CGDTalks, and we will compile some of the questions that are coming in through that channel. But first, we'll go to the room. We'll take 2 or 3 questions, and then I'll turn to the panelists, and then I'll go to some of the internet questions. So we'll go first to you. And please just say quickly who you are and any affiliation.
Yes, thank you very much. This was absolutely fascinating. My name is Jerry Hush. I'm a professor of sociology, and I actually worked at WHO during the time of SARS, and I've been involved with watching this process. So I think I have sort of 2 questions. One is I'd like to broaden the scope of discussion. I've been hearing a lot in terms of epidemiological data, but I'm really interested. I'm coming from a One Health perspective and social context, and I'd really like to hear about what we call the social determinants of this, because there are very real what I call micro actions that have to do with the way in which people interact and disease moves. So that's the first one. The second one is I'm really curious about the global governance institutional response. Having sat in WHO and listening to the conversation yet again, and I appreciate what you're dealing with, I really am curious as to whether what I call a complex systems perspective has been introduced. Not simply a systems perspective, which is very linear, but the kind of analyses, really multidimensional analyses that need to be done, especially in terms of new technologies and the capacity to work with greater data sets, an ecosystem model, if you will. So I have those 2 questions. Thank you.
Thank you very much. I'm Ed Elmendorf. I used to be with the World Bank. Building on the previous question, I wanted to pursue that even further and ask the panel about their assessment of the institutional and political capacity of the global institutions to address this dimension, maybe also their financial capacity. The second question concerns the communication dimensions, and Dan referred to that a little bit. I want to push that further in an environment where the public confidence in what our leaders are saying is falling. And what do we do about it? Thank you.
Yeah, that's a simple and easy one, I think. And here, and then we'll turn back to the panel.
My name is Kay Oshel. I'm a retired federal employee. This is a very layperson's question, but I heard on the news about China using a lung scan testing, and is it testing now a blood test? And in view of the importance of test, what is the significance of these developments?
Okay, great. Great. So we'll take those, and then I'll read out some of the questions that we're getting from the internet after we take this round. Jen, could we maybe start with you? What's your I'm curious for your take, particularly on the social determinants question, and that relates to behaviors and it relates to how we try to get people to change, and also if you have a read on the diagnostic or whatever else you want to touch on.
So it's a great question. I just don't think we really know, but it's an important one, and not to keep bringing it back to epidemiology because I'm an epidemiologist and that's what I do, but I think it's really important to be asking those questions of the data that we're seeing. And so one of the things that we've been wrestling with is this discrepancy in clinical outcomes in China versus outside of China, and why is that? Is it the symptom of just larger numbers of cases? And if we had those sort of numbers elsewhere, we would see similar trends. Is it a symptom of the people who have come from outside are healthier just because they're travelers and that's who tends to travel? That hasn't been all of the cases, so to me that's not quite the answer. Is it what we are seeing in China a product of being in China? Perhaps there's something there that is making it harder to recover, perhaps because they're so stressed with cases that the medical care is not what it would otherwise be, or because there's something in the environment like air pollution, smoking, whatever, that makes it more likely to experience complications. Are we seeing these clusters of severity because of age structure or underlying prevalence of chronic illness that we know is associated with increased likelihood of developing severe outcomes from respiratory viruses? We don't know, and I think all of these are questions that we should be asking of the data and kind of putting a question mark next to it when we think about extrapolating to other environments. You also asked a question about the complex systems, and I'm not sure I fully understand that question, so maybe I'll leave it to somebody else. But then there was a question about the diagnostic strategy. So what appears to be happening in Hubei, I believe this is actually limited to Hubei, that they are allowing for clinical diagnoses, which seems to include, but it's not clear to me that it needs to include like a chest x-ray or some kind of CT to see if there's evidence of lung, like a pneumonia. So apparently what has driven this is that it has been taking too long and there are shortages in testing and just they can't meet the need. And so the clinicians have pushed for there to be a clinical diagnosis of illness so they can think about treating their patients, cohorting their patients, et cetera. What this will mean for our case numbers, I think there's a bit of a question mark next to it, because on one hand, we might be capturing more cases than we would otherwise, which could drop our estimates of severity if those are milder. However, if it's contingent on having lung disease or evidence of lung disease, then we could be perhaps biasing it towards more severe cases. I think there's a number of factors that need to be considered.
Yeah, just to follow on that, and federal worker, thank you for your service. And no question is not
And you and every reporter
worthy.
wants to know this question.
Exactly.
So-
So I will refer back to 2001 and the anthrax attacks, where we successfully diagnosed 2 of the inhalation anthrax cases in the Washington, D.C. area, 2 postal workers who came through Inova Fairfax Hospital, and 1,000 other patients who, in a 2-week period of time, came in with a chief complaint thinking they had anthrax. And this is the way that people react, as I mentioned before. Clinical diagnosis is very important, and Jen, at the beginning of her comments, noted the importance of an astute clinician. So let's just think quickly about this novel coronavirus. It's primarily transmitted by respiratory means, but we know that it's been found in the intestinal tract, like other coronaviruses, so it can be spread through diarrhea or vomiting and so on. And the simplest way of getting diagnosis is really a respiratory swab, a nasal swab or oropharyngeal swab. Actually, the blood testing is a little bit less, capable, is my understanding. And so the clinicians, in the absence of a testing kit where they're doing reverse transcriptase PCR, polymerase chain reaction tests to see if there is the virus, are looking at CAT scans primarily because in the first case report of 41 cases that were described about 2 weeks ago now, they described ground glass appearance, which is a type of radiologic finding that we don't know if it's unique just to this coronavirus, but we do see it with other prolific inflammatory reactions. And so the clinician said, look, if I see this, at least on the CAT scan, then I have an inkling that maybe these cases are due to this virus. So I think there's a lot of work still to be done. I don't know if there's anything else to say on that. But
The only thing I would say is that this happened in 2009 when we had the influenza H1N1 pandemic, because there were just enough cases in the community that it no longer made sense to, and they just couldn't keep up from a laboratory standpoint to confirm cases, so they shifted to more of a clinical diagnosis. It was assumed that if you had the symptoms, you likely had the novel H1N1 flu, and you were treated presuming that you did. And WHO has described this shift as in similar manners, that the situation in this particular area has gotten to the point where they are now need to shift their case definition to match what the demand is. And I think we should expect that will happen in other places as case numbers grow, where it becomes less important to enumerate every single case and just use diagnoses, lab confirmation for certain different purposes, perhaps to, rule in or out other things. But the fact that 1 million reporters are calling asking this question means that we should anticipate when we have this shift, as happened in 2009, we got the same sorts of questions from reporters, like, why are they shifting? What does this mean? Does this mean that people aren't going to be counted? These are all, they're going to be informational needs that health authorities, et cetera, will have to be able to explain, and to the extent to which they can explain what the triggers for that are, so it doesn't seem like a rash decision in the face of being overwhelmed versus, okay, we've reached the point where we have predetermined that we will now do this.
And Saira, I don't know if you're still with us on the line.
Yeah.
She is brilliant. So I wonder, you mentioned the challenges with testing, with the testing turnaround that you're seeing already in this country. Would something like a switch to this different diagnostic be helpful to you in alleviating those? Or is that a tool you'd want in your toolkit now, or is it something that should wait till later on?
I think right now would be great because we're already seeing impacts to, PPE, and when we're having a turnaround time currently right now of, upwards of almost 2 to 3 days, we're already having staff go obviously into the patient isolation room, on a regular basis, and so they're burning through PPE. So right now we want to conserve as much as possible, bracing for a potential, obviously, pandemic situation where we're going to need, even more PPE supplies, if you will. So I think right now would be the best time to employ such a diagnostic device, and if we can even have a bedside, that would be even better. But right now we understand that obviously FDA has authorized local public health labs to do the diagnostic assay. It's just a matter of time, hopefully, that comes up and running, but we'll see what the turnaround time looks like for that.
Great. Tolbert, could I turn to you? There was a mention of One Health, and I know that's something you've worked on. So I'd be curious what role, or kind of how do you see that playing into the preparedness and response here? Jen's point, I think, is so interesting too, that there's a huge amount of public interest and media interest every time there is a change in procedure, and that gets to the community engagement and the trust issues that you were talking about. So what should be, what should we be thinking about how to communicate effectively with the public as this response evolves, and what should we be doing to maintain that sort of trust?
Thank you. I think the issue of One Health and taking the One Health approach is very, very much important. For now, and everybody is scrambling, looking at, we have the disease in the human population right now. Mm-hmm. But if you look at the anthropology of the disease and look at what we're dealing with, especially in the developing world and other areas with the One Health approach, when you look at the involvement of animals, and OIE, which is the sister organization of WHO, is reporting that with the literature we're looking at, 75% of the pathogens that affect us now are from animal origin. And so if I gave you examples with Ebola coming from bats, and we've done a research in Liberia that shows that bats carry the Ebola viral disease, especially the virulent strain that we're dealing with, the Ebola Zaire. And we're dealing with rabies from dogs and Lassa fever from rodents and all of that. And all of these things come from the environment and animals. So working together as a team with One Health approach, I think from the very beginning, these are things we need to look at, because human population are getting very, very close to these animal species and other things because of deforestation and other things that are happening. So putting in a communication mechanism from the One Health approach and dealing with that. And we've done similar thing in Liberia, having a robust One Health program. That's interaction between the Ministry of Agriculture, the Ministry of Health, the Ministry of Energy, the Environment, and dealing with other children, community engagement consistently. Talking about these things is very, very critical.
Yeah. Yeah, and I think that it echoes too the point, Dan, that you made earlier, that part of moving to a crisis standards posture is not just outlining what the standards are, but also socializing those with the providers and socializing those with the communities.
Yeah, and I would draw exactly right, and I would draw that back to the question about how to portray difficult information in this age of disinformation, and I think that. We need to be being proactive about it now. We need to think about it, and I'll tell you, I'm going to use a sports analogy. I think this is an American football game because the anti-vaxxers are beginning to line up on the 50-yard line, and they're beginning to sort of rev up their engines as we begin to look at supply chain response with regards to countermeasures and hopefully a vaccine eventually, and they are going to state all the crazy disinformation that we know comes with these sorts of events. And we need to match them on the 50-yard line with science, with truth, trust, and transparency, as we say at In-Q-Tel. We need to be able to really identify where there is scientific evidence, and we have to have the right speakers who can come out and portray that information, share it, explain it. In this country, I think our chief spokesman is Tony Fauci. He does an excellent job at every turn, wherever he is. And I think we need to build those ranks and be prepared to match the sort of disinformation that we can anticipate is going to come.
Yeah, I've noticed on Twitter in the past few days there's been a distinct uptick in what you might call the coronavirus truther movement. Starting to show up quite vocally on this. So I think that's a great point. Prashant, the question about complex systems, how does that how do we navigate that in terms of the sort of supply chain disruption issues that you were talking about? And is this a sort of global governance gap that we have right now, that we don't have the structures and systems in place that would be needed at an inter-country level to manage this challenge and kind of make these decisions about scarce resource allocation?
So I don't know if I can answer the question about do we have the global institutional governance, but I think to your question about are we using complex systems methodology in a meaningful way, the answer is if you look at the number of modeling studies that are coming out on the preprint servers this time and what kind of data sets they are using versus in 2014 versus in 2009, what you'll find is that people in the epi modeling community have started using novel data sets. And so in a sense, they are going beyond what was narrowly called, these are the data sets we'll look at for epi. So that's a positive development. We also are seeing a lot more inter-organization collaboration in what's coming out in the preprint servers. So in that sense, they are starting to realize that this is a complex system requirement, but it's in a self-organized manner. There is not an institutional home for it in HHS or at WHO. These are self-organized movements of people who are saying, oh, you are a supply chain modeler, I'm an epi modeler, let's get together because together we can find better solutions to this problem. So what we need to do better is in the institutional governance structures, both in the US and globally, create a home which acknowledges that it's a complex systems problem and brings those two people together. And one thing I'd like to comment about, what is the right agency and do we have the right global institutional structures? I think it's important to think about that on two dimensions. One is, what is the right governance structure and technical agency for doing the technical work? The other is, much of global health security, as you all know, is about diplomacy. And which is the agency which is better in terms of global diplomacy versus bilateral diplomacy? So I think things are dynamic and keep shifting in terms of where we are in our ability to use bilateral diplomacy versus multilateral global diplomacy. So I think at least ensuring that lens is kept in mind. And then a quick point on the testing method. So I think it has, like Sarah was pointing out, there are some supply chain components to what kind of diagnostic method is used. So one is the simple one around the attack time, but also does it strain the PPE system more or less? And how much dependency does it create on a reagent and a specimen transport need versus on-site results determination? I think we often overlook that there is a supplies component attached to the kind of diagnostic strategy in place.
Right. I want to read a couple questions that we've gotten off Twitter, and then I'll turn back for another round here in the room. And a couple of these also echo some of the points in the earlier questions. So there's a question, I think, particularly for you, Tolbert, on financial support. And there was a question earlier, too, about the capacity of financial institutions to handle what may be coming. So that's one question, is how financially ready are we, particularly in the developing world, for the burden that this disease could pose? Next, a question about crisis care standards, and specifically about ventilators, that if the outbreak gets considerably worse, how much of a rate limiter in terms of treatment capacity is the availability of ventilators, and how would that be managed? And then finally, and I think you've touched on this a bit already, Prashant, but what challenges are we likely to face, and what remedies might we have for the rapid rollout of tests or other materials if we start to see really large-scale disruptions to supply chain? And what's the remedy there? So, Tolbert, can I maybe go first to you on the financing question?
On the financing, it depends. Actually, the scale and magnitude of the outbreak that we're dealing with. Looking at what we know right now, we really don't know it, not on the coronavirus disease and what is happening, but if you give it what we experienced with the Ebola outbreak, we are better prepared a little bit financially as compared to before Ebola. Post Ebola, I can safely say with the mechanisms that have been put in place for crisis management windows, like for the World Bank, the US government with the global health security agenda resources that are out there already preparing systems, you can safely say that there are some systems and resources to start with. But as the outbreak gets bigger, to the extent that we saw with Ebola, while the peak of the Ebola season, then it will require extra resources because looking at the economic situation in the developing world right now, with countries struggling to support the regular and routine healthcare system, and to further combat it with an outbreak of a disease of such a magnitude that we saw with Ebola, then you have to worry a little bit about the financing. And this is what having some catalytic resources that can be easily tapped on and used in the developing world will play a crucial role. Dealing with organizations like WHO that are on the ground, organizations like the Africa CDC, improving the services of the public health institutes on the ground, and Ministry of Health will play a critical role in galvanizing resources.
Prashant, what remedies might we have, or what strategies would you want to look at deploying if we begin to see these really large disruptions?
So I think the biggest barrier is going to be something very simple, which is interagency communication and coordination. Right? I mean, the moment we have clarity on a rollout plan, whether it is for a new form of diagnosis or a medical countermeasure if it becomes available, just combining the supply side with what Dan talked about as standards of care in a crisis, that getting communicated to different actors will be our biggest challenge. I think in terms of building surge capacity, we do have some mechanisms in the US which can very quickly be put in place for a new antiviral agent. So we have mechanisms. Globally, we will face a challenge. The one thing that works in favor of the way developing country procurement occurs is that even though in most of my other work I am very critical of the idea that why does a developing country government purchase its entire year of medicine stock in one go and stores it, they should buy more often, that leads to efficiency. Many countries do have stock of basic anti-infectives sitting in large quantities or whatever drugs are needed outside the medical countermeasures. So that's a little bit of a positive side. And I think we do need, again, stressing the point of a global coordination mechanism for supplies alone. UNICEF, for example, with PPE had done a good job in 2014, but we still don't have the right sort of global structure for a supply coordination mechanism.
And to add on that, based on my experience, there are organizations that are also on the field that we learned was able to gather a lot of support when it comes to supply chain. WFP done a great job to look at cross-docks, building supply chain warehouses, forecasting for based on the kind of disease that we were dealing with. Some of the PPEs to get it in very fast. And one important area we shouldn't leave out in the supply chain sphere, and it's good for me to mention that based on my experience, the military did a very great job in moving supplies at a very good speed that civilian organizations could not do. So let's put that in our toolkits in moving supplies, building treatment units, if these things get to the level that we see the military should be in terms of supply movement.
I think it's so important when we talk about these supply chain issues to view it through the lens of a pandemic, because we may be tempted to think, okay, the U.S. relies on, much of what the U.S. uses is produced in China, the raw materials for medicines, PPE. But we have to look at it in a global context because, some of these raw materials are then shipped to other countries where then there's the next step that's produced. And while it may be tempting to think, okay, well, we'll just try to find another supplier for it, when all of the world has the same demands, and when you layer politics on top of that, I'm just reflecting on 2009 when we had contracts with an Australian vaccine manufacturer who informed the United States that they would fulfill the contracts after they met Australian contract requirements. And to think about the countries that are the places where parts of these products, if not the products, are made, and what what their demand or what restrictions they may place on those the movement of those products. It's hard for us because we don't have that much experience, but sometimes we view it through the lens of, well, this is what happened when there was one affected region and then we needed to pull things from a different place. I think there will need to be global governance, but I also think in those circumstances where all countries are clamoring, or many countries are clamoring, that politics may just overthrow those approaches.
So there's a pretty significant global governance gap there, and if push comes to shove, politics and national interest are going to trump commercial contracts.
Right, so the US also in 2009 said that we would give 10% of our vaccine stockpile to a global stockpile that could be used elsewhere, and the Congress, actually it was Democrats in the Congress, despite a Democratic president, said not until all of the United States is vaccinated, and so I think we just have to factor in those wild cards.
Prashant, did you want to add something else?
Yes, I think what we saw, for example, a few weeks ago was that India put an export ban on all PPE, right? And so that means the third largest or second largest producer of PPE says nothing can be exported outside. And what is critical is that before we truly get into pandemic mode, we still have an opportunity to resolve some of these issues. Once we get into pandemic mode, it will be that every country would say, well, whatever sources of supply I have are only for citizens or constituents of our country. So I think it's important to get that part right soon.
Dan, do you want to say anything on the ventilator issue?
Yeah, so the ventilators are a limited resource, and it always comes up in the context of discussions around the potential transition towards crisis standards of care. I want to highlight three critical points with regards to this coronavirus. First, what we know of the severity of this illness, as has been stated earlier, is that it is mostly mild in most cases. And in the limited epidemiologic data, clinical data that's coming out of China, case reports and so on that have been in the peer-reviewed publications, somewhere just under a quarter of patients, 23% I think it was, required intensive level care. We really don't have a lot of information thus far in terms of how many have been intubated, for how long, what level of respiratory support has been required. That's the first thing. Now I'm going to step out on a limb on the epidemiologic risk factors and say that perhaps in China and perhaps in Wuhan and Hubei province, where there's probably a much higher predominance of smoking and probably a much higher level of ambient air pollution, those may be contributing factors to the respiratory illness and therefore may explain in part why there has been this 25% or so requiring advanced level care. That being said, I'll go back to what I stated initially. Ventilators are a rate limiting factor. And the fact is that from a clinical perspective, we really are not very good at being able to prognosticate who is going to do better on a ventilator and who isn't going to do better on a ventilator. We have some clinical decision support tools. The one that has been most notably mentioned in the peer-reviewed literature over the last decade has been the sequential organ failure assessment score, which was never intended to look prospectively at how patients do once they're in an ICU on a ventilator. But it can be used to compare patients. And at the very least, I think that what we have advocated, we've published in the literature and so on, is that critical care physicians and ICUs and others who are routinely responsible for caring for the sickest of those patients across the wide spectrum of illness that they care for should begin to put in place the kinds of contingency or crisis plans that would recognize if ventilators were in short supply, what they would do. And that comes to, again, some of the principles that I talked about earlier, like substitution. Can you maintain a patient on high flow, positive pressure ventilation in place instead of putting them on a ventilator? Can you identify certain patients who with other comorbidities are not likely to improve and therefore maybe would have a trial run at a ventilator attempted and then move that ventilator to somebody who is more likely to survive. So these are difficult decisions, and because it's a finite resource that is a life-saving resource, it's worthy at least of discussion and contemplation and planning ahead if it were to come to that.
Yeah, we'll turn back to the room for, I think, one last round of questions. I know I saw one in the back. Before I do that, want to see, Saira, if you're still with us, did you want to weigh in on any of these last round of questions? I think we may have lost her. I know she has an actual hospital system to prepare for a potential pandemic. So let's go there in the back, and then we'll come here in the front.
Thank you very much. My name is Ok Pannenborg. I used to be the chief health scientist at the World Bank before I retired. I would like to take a little step further of Dr. Tolbert, who I worked with when he was minister in Liberia under the Ebola activity, on your One Health issue. I think it's very important.
Thank you.
It's important both from the current addressing of any of these zoonotic infections, but it's especially important with regard to the future. As you highlighted properly, this is the current situation, but this thing will come again in the future. So, well, most of you are younger than I am, but the future looks, we need to engage with the young generation, meaning the students in medical schools, and from the One Health perspective, the veterinarians. When you and I were in medical school, the exposure of our education to infectious diseases, if we were lucky, it was 10% or 20%. Veterinarians in their school spent 60% of their education on infectious diseases. So the combination of clinicians and medical professionals on the human side and the veterinarians on the animal side is, I think, an agenda that obviously is part of the One Health, but it's under-highlighted. Yeah. So I would strongly urge even CGD to pursue this a little bit more. How can we institutionalize much closer collaboration between veterinarians and specialists in infectious diseases, including pandemics, etc., in the future, including the collaboration specifically for the new generation, meaning medical schools and veterinary schools. Right. There are a few that work together. Yep. That's, for example, Ahmadu Bello University in Nigeria, where they're next to each other, but it's rare. Okay. So that's an agenda for the future.
Thank you very much for that.
Thank you.
We had a question here.
Thank you. Katie Wang with NTD TV. First, I want to give a quick response or comments about the question you have raised about why outside China we have seen the symptoms of the patients is much milder than the symptoms that inside China. Based on our interview, we find that like the city of Wuhan, many patients, when they have symptoms, they went to the hospital, but the hospitals, they have only very limited of testing kits. Mm-hmm. So the doctor told the patient that they can only use those to those have very serious symptoms or very ill patients. Mm-hmm. So that means only limited number of patients can be confirmed that they have this virus. So people with light symptoms couldn't be, they can only be regarded as suspected. And so that's one factor I think could contribute to this. My question is, we see Chinese government handling this public health crisis. At the beginning, they try to cover it up. The local official and even the central officials, they try to cover it up. But later on, they use some very extreme measures, like lock down many of the big cities, even the provinces inside China. And now they can also concern about the economic issues. So they ask those manufacturers to resume production. Mm-hmm. And so I'm wondering, many of these measurements seems not very scientific. So what should be the right measurements we took when we faced such a big crisis? And so that's the main question. Thank you.
Do we have any more in the room? We'll go there, and that will be our last question. Then we'll turn back to the group.
Hi, I'm Nadia Shapok, and I'm a research intern with the Humanitarian Agenda at the Center for Strategic and International Studies. My question is two-pronged. So firstly, how should humanitarian organizations prepare to address possible pandemics and conflict zones in developing countries? And I know you mentioned healthcare workers becoming infected in the Wuhan province, but how, in light of increasing regulations and de-risking policies, how should field workers on the ground protect themselves in an environment when supplies and quality of humanitarian assistance is affected negatively?
Thanks. All right, I think we'll end the questions there. I'll turn back to everyone on our panel to respond to those, and then share any last reflections they might have, and then I think we'll be about at time. Prashant, maybe we can start with you. Do you see a role for? I'm curious on the humanitarian front. Do you see a role for humanitarian organizations in this, and what other factors should they be thinking about? And then any other thoughts you might have on those questions, or kind of a final reflections.
Yes, I think similar to what Tolbert was describing about the UN World Food Program, I think much of the effort in delivering medical countermeasures or even PPE in a pandemic setting starts to look much closer to a disaster or other forms of crisis. And our regular supply channels aren't designed to cope with that.
Yeah.
So we have to rely on an alternative supply channel, which is oftentimes our best channel actors are humanitarian agencies. I'm not in a position to answer the question about what do we do about healthcare professionals when the quality of humanitarian supplies is both limited and not in abundance. But I think there is a clear role for humanitarian actors, especially in the medical countermeasures supply chain business. The question that comes out of that, once again, is how does the humanitarian supply chain actor interface with the broader health system, because they may not be routinely a part of health system discussions, right? The food program is about food, or the other humanitarian actors are about other kinds of disaster relief supplies. So how do we create interfaces for them to fit into the health system when such a need arises?
So, and Tolbert, I'm sure you have thoughts on this, because ultimately the humanitarian community played a large role, but not always a comfortable fit at the outset, because they weren't so used to working this way.
I have seen the worst case scenario, and we don't anticipate that, but you have to be prepared for that. The humanitarian organizations, they have a very, very crucial and critical role to play. I've seen where we had to outsource the dead body management of the people that were dying, because in huge numbers. We had to look up to humanitarian organizations to manage cases in the treatment units. We had to look up to humanitarian organizations to move into community, to do the community engagement. Supply chain, obviously, is one of the critical component of that. Getting the IPC measures, that's the infection prevention and control measures for healthcare workers to be safe. We lost almost 180-something plus healthcare workers in Liberia, and in the region, almost 300 healthcare workers because of lack of safety, PPEs that they should use to protect themselves. So humanitarian workers should be really on a standby if we get the worst case scenario that we saw in West Africa. And one of the issues that, Jamie, that I want to throw light on is from our colleague here on suppressing the reporting of the disease. It has a lot of implications. Mm-hmm. Countries that are affected with infectious diseases like this sometimes get isolated, as we see. Jean has been on the news a lot about making sure that we don't isolate the people that are affected by the disease, but the population. The economics of that is a whole thing that we have to look at. Countries suspending flights. I went through situation that are in Liberia where flights were suspended, borders were closed, trade and everything was suspended. The economy of Liberia dropped from 8% GDP to up to 0% GDP because of an outbreak of Ebola. And today, the government is still struggling to build the economy because of some of these issues. So it has implication, but that's the politics of public health.
You know, just one point on the way that information was handled coming from China, and all the points you made I think are correct. But they did release the genome, and we were able to get some sequencing done, and that was shared globally much faster than in previous coronavirus outbreaks, especially SARS. Was there pressure there? We don't know. Was that the scientific community acting on its own? We don't know. However, you know, that's a small silver lining in an otherwise troubling, retrospective review of how quickly or not the information was shared.
Yeah. The question on whether some of these extreme measures have aggravated the disruption, and whether we should look to replicate or take a different approach in other places. Jen, what do you think on that?
So I was very worried about the extreme measures from the beginning, because I think we need to consider what the unintended consequences of these measures are. Yes, we have to protect public health, but we shouldn't do so by implementing measures that are worse for our societies and our people than potentially the virus itself. And so when you think of locking or restricting movement in huge ways, you have to think about, even though there may be an authority, what is the potential compromised life like in those areas. And so when you hear stories about people having to walk to health facilities because of restrictions in transport, it's hard to think that that would be beneficial to controlling the now, I think, borderline pandemic. The other challenge that I see, and I'm pleased to see the message is shifting to one of get back to work, because we do worry about the cascading effects of societies shutting down and what that means, not just for China, but globally. The challenge is, unless we get rid of this virus like we did for SARS, if it's still circulating in the world, and you still have people who are susceptible because they were not infected the first time, even if the measures happen to have been successful. China's a global economy. There will be transport. People will come back. It never seemed clear what the end game would be through the application of these measures. Maybe in the beginning there was hope that we could stop the transmission fully. I think it's increasingly clear that that's going to be unlikely. And so I think it's quite important for societies to get back to work and to think about how we can mitigate the impacts of this virus such that we are protecting those who we think are most vulnerable to suffer severe outcomes, making sure we're able that people who are mildly ill but then their condition worsens, that they have a way to get to seek care, that we preserve the care so that we can try to save as many lives as possible.
Yeah, I just want to comment on the potential for seasonality, which again, we don't know, and it's been a discussion and a potential concern. We do know there are 250,000 workers who come back and forth from China to sub-Saharan Africa, and that is a regular process. And the distinction between this coronavirus and SARS was never seen in the Southern Hemisphere. It was only mostly, predominantly in Hong Kong and China and in Canada. It was never seen in the Southern Hemisphere. If this virus does take root in Africa and in South America, there could be a seasonality. And this is, again, something that is being surmised. We don't know. But it could potentially portend the fact that this will be like influenza, a seasonal endemic illness that we see from season to season. And so to that end, I'm not saying that these draconian measures work or don't work, but I think the notion of containment, I think, is what was driving these early decisions in the hopes of trying to limit spread.
Yeah, but so far it doesn't seem to have.
No, and we're seeing a lot of, I think that Singapore is a worrisome example where we're seeing a lot of transmission in a warmer climate.
Exactly.
And I know people are hoping that this will end when the temperatures rise, but.
So it won't miraculously end in April.
Let's hope
as
it
far
does.
as we
Let's
know.
hope it
Let's
does.
hope it does. Tolbert, do you want to add anything just on the question? Well, both Tolbert and you and Jen both work for an educational institution, so this question of how to better align between schools of public health and medical schools and veterinary schools. What should we be doing on that? What should be happening there?
Well, reflecting on our Hopkins experience, I have to say I've been very pleased by how seriously the university has taken this. I actually went to was invited to participate in a medical school class that was learning about the international health regulations and public health emergencies of international concern, and they were doing a whole feature on the coronavirus, which I was so glad to see that there's time in the curriculum in the School of Medicine devoted to this. But I think we absolutely have to do more, and particularly linkages on the vet side, simply because I think we as medical and public health professionals need to learn from our veterinary colleagues, and the more opportunities we have to learn from them, the better. I think they have a tremendous amount of knowledge to share with us that we don't avail ourselves nearly enough.
I think as an academic institution from the Johns Hopkins School of Public Health, some of the things that we're doing is to make sure that we educate the public with the right information based on data and science. And some of the things that we're doing is that talking to not even medical institutions, but going to business institutions and looking at the economic impact of the disease. I should be speaking at the Career Business School next week on some of these issues as a School of Public Health to give our perspective from the public health perspective.
Prashant, final thought on that?
Yeah, so I think in addition to the Center for Rural Development, I also teach at a business school called INSEAD, and many of our faculty and researchers are focused on where in disease outbreaks is the role of people with business training. And when I say business training, means people who look at how to create uptake for a new health technology, people who work like me on logistics and supply issues, but also those who design governance and strategy things. So I think there is an increasing interest in schools outside of public health and medicine in seeing how they can contribute. We just haven't explored that to the limits of what can be done with it. So glad, Tolbert, you're going out and doing a talk at a business school.
Right.
Yeah, and I would just say, the system of systems question, the complex systems question earlier, I think brings us back to the point that to solve these complicated and complex problems, we're going to require interdisciplinary coordination and cooperation. And that means that we need to be thinking about this at the earliest parts of our advanced education and be able to have thoughtful leaders in the next generation, whether they're in the social sciences, humanities, or in the natural sciences and public health and medicine, think together around these concepts. And I think that is critically important. I mean, all of us as educators ought to be promoting that at every turn.
It's fantastic. So many interesting points and kind of action points coming out of this conversation. I want to just summarize a few of them. We've clearly got a significant governance gap around some of the global level challenges that this could entail, and that's clearly true on supply chain and PPE, but it could also be true on financing. It could also be true on broader elements of response strategy. So that will need to be addressed, and it probably goes beyond what WHO on its own can do. A pretty urgent message that we need to begin planning now for these sorts of scenarios. Once the pandemic arrives, if it arrives, it will really be too late to get some of these structures and systems in place. So we need to take advantage of the window that we have now to do some prep work and advanced work on that, so we have more of a platform ready when and if we need it. A number of comments relating back to this idea of the second-order disruption effects of a pandemic, that it's not just the actual sick people getting sick, but it's the fear and the behavioral changes and the disruption that goes along with that causes a lot of the disruption, whether that's the closure of factories, whether that's people beginning to flood into ERs, whether or not they actually have the disease itself. The fear and the panic and the disruption that goes along with that can account for a disproportionate impact relative to just the disease on its own. And I think this fascinating idea that we need to more proactively create these interdisciplinary spaces where, whether that's the epi modelers talking to the supply chain modelers, or the veterinary students talking to the medical students, or, as we saw in Ebola, the humanitarians talking to the public health community. That's the kind of configuration that we need to effectively manage and hopefully beat these kind of complex outbreaks. And when you're dealing with complex systems, by definition, no single system or single discipline has everything that's required to beat it. And so all of those things need to be pulled together. And we're not always very good at creating and fostering those kinds of spaces. It's been a fantastic conversation. I think it points to some challenging but hopefully tractable and actionable steps that the U.S. and global leaders need to be taking to try and get out further ahead of this. So I'd like you to all join me in thanking our panelists for a great discussion. And thank you all for coming today. And to those online, if you're still with us, thanks so much for joining.